This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey folks, Eric back with you. Today we're going to do a quick podcast, probably 10 or 15 minutes on ketamine. Before we start though, I just want to give a plug to SMAC 2015. It's going to be coming up here in about 6 weeks. If you haven't registered, you can go on the SMAC 2015 website and register for that. There's some amazing speakers from all over the world. The main emergency medicine intensivist from around the world that I look up to. I'm real excited to get to go this year, and my wife and I will be traveling up there to Chicago. We're going to just spend one day just based on my schedule and her schedule. It's really all that we can get away, but we're going to be doing the full day on the 24th. So for those of you that are heading up there, and I haven't met you, I really look forward to meeting you. Going to be a lot of people that I'm going to be excited to meet, and please, if you see me, come up and introduce yourself. Again, I'd love to meet all the people that listen to the FlightBridgeED podcast, as I'm going to seek out other people that that I have wanted to meet for quite a while. So again, go on the website. You can check it out. There's tons of pre-conference topics, amazing topics, or you can register for just a single day or multiple days as a delegate. Before we start on the ketamine, again, I just want to thank everybody. Our listenership is skyrocketing. I just looked at the numbers, and I was talking to my wife and Evan about this, and we're 92% increase from last year. So that is a true testament to you guys for, word of mouth, for telling everybody about the FlightBridgeED podcast. I think any company would die to have a 92% increase in growth in 1 year. So that's pretty amazing. And again, I'm truly humbled by that. So let's jump into this podcast. I'm going to start off with kind of a case study, kind of give you an example of how this can really apply to your clinical practice, and then we'll dive into ketamine and we'll talk about the different aspects, and then we'll wrap it up. And again, hopefully 10 or 15 minutes. So I'm going to use a flight that I just had because I was blown away by the medication, how the medication applied to this patient, and the pharmacodynamics that the medication or what I witnessed based on this medication. So you have a 50-year-old male patient, you're toned, you land on scene, and you're told there's massive hemorrhage, right? You arrive on scene, you get in the back of the ambulance, and you have this male patient that is extremely anxious. He's got a GCS of about 10. He's pale, he's gray looking, and he's diaphoretic. So those few things for me, if I have a trauma patient that I get on scene and I'm on scene very, very quickly, and they're already pale, gray, and they're diaphoretic specifically, if you have a trauma patient that's diaphoretic at that point, that is a very ominous thing. You should be very concerned. You should be very aggressive with getting off the scene quickly, because that patient likely will arrest on you. For some reason at that point, the blood loss, the massive hemorrhage has been so excessive based on the injury, whether it's externally or internal bleeding, hemorrhage, that this patient is really circling the drain. We arrive on scene, we find this patient in this state. We go through and identify really quickly that this patient has no radial pulse. He has no femoral pulse. He does have a carotid pulse. He's got 3 stab wounds. He's got a stab wound to the right lateral neck, right at the carotid artery. He's got arterial spurting from that wound. He's got a stab wound to the right anterior chest, and he's got an associated tension pneumothorax there, and he's got a stab wound to the left upper quadrant, about the 12th rib. You note that the wound in the left upper quadrant, the wound in the right anterior chest, both of those are bandaged. There's an occlusive dressing on the chest wound, but he does have a tension pneumo. So you quickly do a chest decompression to deal with that life threat. You identify very, very quickly that you need to manage this airway. So he's hemodynamically unstable. We talked about in previous podcasts the need for possible push dose pressors in the HEMS pre-hospital environment. So this patient is a perfect example. If you give him a medication that is going to vasodilate him you're going to potentially lose any compensation. But again, I've talked many, many times about airway management, and our best success is always to perform full RSI. That means giving some type of induction agent, some type of pain management agent, and full paralyzation. And we did a podcast on passive oxygenation. I talked about sucks versus rock, the likelihood of desaturation, and the whole point of nitrogen washout and optimizing that with passive oxygenation techniques. So we go through all those steps. We do passive oxygenation techniques, and we choose to go with ketamine. This patient is extremely unstable. I'm a big fan for giving fentanyl in RSI, but in this situation, I chose, based on conversing with my partner, we skipped the fentanyl and we went straight and we chose ketamine as our induction agent. Now remember, ketamine is something that we can use for both pain and sedation. It has that anesthesia type effect, but it also has great analgesic effects. And we've talked many times on podcasts previous that our pain aspect of intubation is massive. And we have to really be cognizant of that during our intubation, during our RSI procedure, but also after, post-intubation management. The pain aspect is the biggest thing we have to deal with. And this is a big passion of mine, is educating clinicians, educating nurses and paramedics about proper understanding of intubation and how the pain aspect drives everything we do. It's not about the sedation, guys. It's about the pain management. And if we use medications like fentanyl, like ketamine correctly and liberally, medications that are great as far as keeping hemodynamic stability at an even keel, we will treat the pain just by using those medications and using them liberally. You're going to have great sedative effects as well. And, your patients are going to be very, very comfortable. So at this point, we give a dose of ketamine. So now ketamine, we have to understand, is a non-barbiturate anesthetic. The dosing range for RSI is very, very wide. It's 1 to 4.5 milligrams per kilogram, but those higher doses are more IM doses. So, you start getting into the 4.5 milligrams per kilogram dose. That's where you're going to give this medication IM. And we'll discuss that here in a little bit. But the standard starting dose for RSI is 2 milligrams per kilogram. So, give 2 milligrams per kilogram. Now, this patient was about 125 kilograms, so we gave 250 milligrams of ketamine. Now, remember, this patient has massive hemorrhage. I mean, he's lost a huge amount of blood. He's lost a couple liters of blood. He's got massive spurting out of that neck. Having somebody on the ambulance hold this pressure on this neck wound constantly, and he has only a carotid pulse, so his blood pressure was below 60 systolic. Now, we give the 250 of ketamine, we give 200 milligrams of succinylcholine, and we see no drop in hemodynamic status. We don't see any drop in heart rate. He's still maintaining a heart rate that's hovering around 100. He's going in between 95 to about 105 in that range. So for me, that's he should be higher than that. He should be compensating more than that. So we have to be, looking at that closely. But the ketamine, the succinylcholine had no effect on this patient. And why is that? Well, one of the things you have to realize with ketamine is ketamine will actually cause an increase in blood pressure. It causes a vasoconstriction. So you're going to have an initial systolic blood pressure increase by 20 to 40 millimeters of mercury in the first 3 to 5 minutes. So this is a perfect thing for this patient. You're not giving a patient etomidate where you're going to have a big vasogenic type reaction. You're giving them a medication that's dealing with, number one, their pain. It's giving them that anesthetic effect, and you're improving hemodynamic status. Or why else would you give any other medication? I just think it's just absolutely phenomenal. So it increases heart rate, it increases cardiac output, it increases myocardial oxygen requirements a little bit. But in this situation, I think when you look at the pros and the cons, a little bit of myocardial oxygen consumption, a little bit of cardiac work is going to be all right. You're getting that cardiac output increase, you're getting that heart rate increase, and you're getting that systolic blood pressure increase, and this patient needs that. So we continue. We load this patient into the helicopter. We put him on the vent. We're given fluids. We're being, somewhat cautious with our fluids, trying to maintain a MAP as close to 60-65 as we can. And the big thing comes now that we have to deal with his post-intubation and his pain and his sedation. Again, we have multiple medications we can go with. We can go with Versed. We can go with Versed and fentanyl. We can go with just fentanyl, or we can go with ketamine. And there's different protocols out there. And again, you need to go based on your protocols. So you have protocols out there where if you're using this for continued anesthesia, you need to give this based on a drip. But you also have protocols out there that you can, if you identify maybe the fentanyl isn't adequate enough dealing with the pain. And remember, this is all objective. I mean, you're going to be dealing with your patient. You're going to be looking at your patient. And your patient, again, as far as intubation goes, and having that ET tube in place and having that positive pressure ventilation, it's always going to be based on the pain. I mean, I can cite many studies that show that the pain aspect is the legitimate main concern. So the ketamine, again, is excellent. It's dealing with the patient. And you're not going to have any respiratory depression, right? You're not going to have respiratory depression. You're going to put this patient in a dissociated state. You're not going to have any drop in blood pressure. You're going to actually have that increase in systolic, increase in heart rate. So this patient is holding on. I mean, this patient, I can't stress how sick a patient like this is. If they've bled out over half of their blood volume and that hemorrhage is continuing, we have to deal with this in a kind of a finite way. We can't flood them with 2, 3, 4 liters of fluid. We know that that's not what the science shows. We used to kill our patients, and we now want to maintain the lowest blood pressure. We want to maintain permissive hypotension. This patient needs FFP. This patient needs packed red blood cells. They need that massive transfusion protocol. So this medication is helping us maintain that MAP in a range that is allowing us to get them to a definitive facility and a surgeon. Some other things that we can talk about with ketamine that are kind of misnomers. The early literature, and I still hear people say this, that ketamine causes an increase in ICP. Well, all the studies have shown that that's actually false. Actually, ketamine is a potent cerebral vasodilator, so I guess you could say that there is a potential that you could cause an increased perfusion to the brain, but it actually increases cerebral blood flow by 60%, and that's with patients in normal capnia. So they have a normal CO2 range in that 35 to 45 range. The studies actually showed that patients with traumatic brain injuries that were mechanically intubated and ventilated had ICP decreases when given ketamine. So that's one positive, right? Don't withhold ketamine because you're worried about increases in ICP. It's actually going to make this patient better off. The biggest thing we have to remember with ICP in any patient, whether that's a burn patient, a trauma patient, or just a neurological insult, whether it's a epidural bleed, subarachnoid, anything related to the brain. The number one cause of increased ICP is pain, and the pain aspect is, again, the biggest part of being intubated. We've had people in our review classes that have actually been in the ICU. They've been intubated for different reasons, and all of them have told me that they never were dealt with adequately enough. They were put on a mode like AC. Their sedation and their pain management was never adequate. They were always uncomfortable. They felt like they were suffocating. They felt horrible. And so, we have to think about that. You have medications now that we carry. It's not like it was 20 years ago where all we really had was morphine. We have ketamine now. We have fentanyl now. And even if your patients are hemodynamically unstable, this patient I just referred to never had blood pressures that were adequate. And most of the time they had blood pressures, his blood pressures were, below 80 systolic. So I can tell you based on using this in multiple patients, not only ketamine but fentanyl, that both of those medications are the ones you want to go with patients that are hemodynamically unstable and need continued pain management and that secondary sedative effect. A few things with ketamine that we have to also remember. This is an excellent medication if you're intubating a patient that's got any type of bronchoconstriction, specifically pediatric patients. We know that there's a mechanism that causes some broncho 2 stimulation. It causes that bronchodilation. It's thought to be more of a secondary catecholamine release that causes this. So you have some catecholamine release, some beta 1, some beta 2. That's where you get that increased heart rate. You get that increase in bronchodilation from that beta 2. So again, excellent in bronchodilation. For me, having the option of going ketamine or etomidate for induction in RSI, I'm always going to go ketamine unless there's a sensitivity to the medication that we can identify. Really, for me, when I look at the pros and the cons, and I have that choice, I'm always going ketamine over etomidate. I just feel like it gives you so many beneficial tools, and I think it's better off. You're better off with your patient. A few things as far as adverse effects, if you want to call them adverse effects, you can have situations where you give ketamine, specifically in pediatric patients, where you're going to give this dose of ketamine and you may see some hypersalivation. And I've had a few people come to me and say that they've experienced this. This isn't a big deal. This actually happens quite often. It's not a rare thing. And you're just going to treat this with atropine. So you're going to give them atropine. Remember, atropine is that anticholinergic medication. That's what's happening. It's causing that stimulation of those cholinergic receptors. And we just give them, a dosing of atropine like we normally would of that 0.02 milligrams per kilogram. And you can drop that or get rid of that. As far as the CNS effects of ketamine that we can use this for, you have a patient that is agitated. You have a patient that, predominantly historically we would RSI. We would RSI them for the safety of the patient, safety of the aircraft crew, and for safe flight. We also know that anytime we intubate a patient, we're increasing the potential for VAP, for ventilator-associated pneumonia, and for other areas of concern, right? Anytime we intubate a patient, we put them on the ventilator, we're actually causing a potential secondary issues, whether it's pneumonia, whether it's aspiration, microaspiration, things like that. So if we can not intubate our patients, and if you know me, I'm very aggressive with airway management. I always will go down that road just to protect their airway, even if they get extubated when we get to that receiving facility. But we now have a medication with ketamine that you can give a patient that is very agitated or needs to be controlled, and you can give them ketamine. You can give them IM doses of ketamine, and it's going to calm them down. I think this would be a great thing in burn patients, great in maybe a psychotic event. And it's being used a lot now in patients with excited delirium. These patients with excited delirium are the ones that police officers will restrain. They'll fight. A lot of times they're thought to be on different psychotic medications like PCP. They're having these psychotic events. They're restrained and they're tased and they're put in the back of a police car, or they're put face down on the highway, and they go into cardiac arrest or they die from that. And it's thought to be, associated to the restraints. It's thought to be associated to, maybe being tased. And this isn't the police officer's fault. This is secondary to an excited delirium, a psychosis, a cerebral issue. And the dissociated effects of ketamine will take care of that. So ketamine is a great medication in that regard to take care of those patients. And you're going to have patients that will calm down. They'll be manageable. Dealing with these patients in the wrong way is what causes them to, succumb to that disease process and die. Ketamine is one of those medications that I think is an all-around medication. I think fentanyl is right up there with it. But the more I use this medication, the more of a fan I am. If you remember back to a movie in 1998, they were referring to the actors in Armageddon, and they were doing all those lab tests. They were all about to go into space, so they were doing those physicals. And the one scientist said that they found ketamine, that it's a horse tranquilizer. Well, that was true. In the past, ketamine was used as a horse tranquilizer, very powerful tranquilizer, and they still use that in tranquilizing animals. They'll use that. So again, ketamine is one of those medications that you should really study. You should look at if you have this medication in your protocol, in your tool bag. I would really encourage you to start playing with this. Anything that we have, anything new that we have, if it's a new medication to you, all you can do is try it. All you can do is become comfortable with it. You're never going to become comfortable and understand the effects of these medications if you don't try them. Remember, you can always give low doses. You can give more low doses. Don't give massive doses, when you're trying things out. If you're worried about hemodynamic instability and you're just unsure and you're more conservative, don't withhold these medications in these patients that are hypotensive. Please don't do that. And I can tell you that as just, poor care, and that's not meant to attack anybody, but that's just truly my thought. If you're not giving patients pain management, even though they're hemodynamically unstable, you're providing poor care. We have medications now that, like I've said many times, ketamine, fentanyl, that will take care of that issue, and it will not have an effect on the hemodynamic instability. And ketamine, again, is one of those ones. And I just experienced that to the T. This patient was one of the sickest trauma patients I've had in a really long time. We did get him to the trauma center. He did go into surgery. I believe he went into cardiac arrest 3 times after we dropped him off. He had a pH when we delivered him before they took him to surgery, a 6.9. The neck wound had basically stopped spurting, so that's an indication that he probably had bled out most of his volume. They immediately started 4 or 5 units of packed red blood cells and FFP and got him surgery, and he so far has survived. So this is, I think, a testament of the ketamine. The ketamine really did help us maintain a good blood pressure. It helped us maintain him. It would have been a very poor thing for us to give him vecuronium, give him a long-acting paralytic. I think as far as fentanyl may have been adequate, but I think the ketamine, the effects on blood pressure, the effects on catecholamine release, and heart rate really did benefit him in this situation. So that's all I have for ketamine. We may do a follow-up podcast on ketamine, on excited delirium and the different uses for ketamine besides the pain and sedation aspect in RSI and in intubated patients. But I just wanted to introduce this. I know many of you have used this and you're currently using this, but this is something that you should be going to first in your tool bag, I think, RSI-wise, in my opinion, and first as far as pain goes. And again, look at your protocol, look at how it's written. Oftentimes the protocol is going to be written where, if you're going to use it for pain, you're going to give some type of narcotic like fentanyl prior. If it's not adequate, if it's not dealing with a patient's pain appropriately and you feel like you need another medication, then go to ketamine. And ketamine, again, is going to be that great additional tool for continued pain management and sedation. So that's all I have. I just want to remind everybody, go to the website, check out the blog, go to the courses. We have a couple courses coming up. If you haven't registered and you're in the area around Alabama, so you're in Georgia, you're in Tennessee, Kentucky, Mississippi, Louisiana, we're having a course in Muscle Shoals, Alabama. Check that out. It's the end of May, May 23rd, 24th, I believe. So go check that out. And we will also have a course in Madison, Wisconsin in June. Again, I'll be traveling to SMAC on June 24th. So if you're there, please say hello. Thank you so much for everybody for listening, for the great emails. I continue to get those. And feel free to always contact me, text me if you have my number. That's what I'm here for. And we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.